Who is the host of this meeting?
So, ma'am, I'll invite you. You have the first this thing. I'll invite you. So
otherwise, I'm saying just who is conducting. There must be somebody now who is managing the.
there is from the Dhira, there is a backend team here.
Who is the backing team? That is what I'm asking.
So Bashir, ma'am.
Bashir.
Yes.
Mr. Bashir.
Yes, ma'am.
How many registration do you have?
What, ma'am?
How many registration do you have? Do you know about it, Bashir?
Yes, ma'am.
How many?
121.
121, but there's only 31, 32 has joined.
Yeah.
So should we wait for another 5 minutes?
As your wish, ma'am.
Ma'am, from Johnpur Society, ma'am, they are joining.
What? Who is talking?
Ma'am, this is Amber. Ma'am, two people joined and ma'am, others are joining, ma'am. Around 12 people have registered. Yes, ma'am, they are joining.
Yeah, because this is the most important talk which I am going to begin is a MTP Amendment Act, which is the heart and soul. So let them join fast and ask them to join fast.
Yes, ma'am. I called them personally, ma'am. They are joining.
Okay, Amber. Thank you. अब अपना जो वीडियो भी ऑन करो, देखें भी तुम्हें. बहुत दिनों से इधर आना जाना नहीं हुआ है ना. अदरवाइज लोग मऊ के तो सब उसमें आते ही थे. गोरखपुर में जितनी मीटिंग्स होती थी उसमें भी तुम लोग आते थे. गोरखपुर, वाराणसी. अपना वो ऑन करो. तुम म्यूटेड हो अंबर.
मैम गोरखपुर कभी नहीं गए मैम, वाराणसी वाले में गए.
वाराणसी.
गोरखपुर जी जी मैम.
वाराणसी के आसपास कौन कौन सी सोसाइटी आती है? तो जौनपुर आती है और मिर्जापुर.
मिर्जापुर है मैम जी. आजमगढ़ है.
मिर्जापुर, आजमगढ़ एंड जौनपुर.
जौनपुर. मऊ भी मैम आसपास में ही, आजमगढ़ से थोड़ा दूर है बस.
ओके. 4 सोसाइटीज आर देयर. और तुम लोग के इलेक्शंस कब है? चेंज ऑफ ऑफिस बेरर कब है अंबर?
मैम एक्चुअली अभी तक हुआ ही नहीं क्योंकि बहुत लेस नंबर है ना मैम मेंबर्स के, तो और ज्यादा लोग एक्टिव होते नहीं है.
कितने हैं तुम्हारे पास?
मैम पहले 18 थे, अब इस साल 4 और बढ़ के 22 हुए हैं.
मैम दिस इज द स्मॉलेस्ट सोसाइटी. एंड द यंग आल्सो वन ऑफ द वेरी रीसेंट.
मिर्जापुर?
मैम मिर्जापुर में हम लोग से ज्यादा है शायद मैम.
अच्छा. एकिका कहाँ की है?
मैम वो मऊ की है.
वो मऊ की है. अच्छा, एकिका मऊ की है
जी.
अभी उसने इलेक्शन जीता है ना?
हाँ मैम.
भाई मैंने कहा कि भैया तुम्हारा नाम मैंने देखा, क्योंकि एकिका नाम ऐसा है ना जो मैंने कभी सुना नहीं था. जैसे मेरा नाम होता था तो लोग पहचानते थे. That is how I said to Ekika also.
There's a request to the backend team. Please mute everybody except the people who are talking. Yeah, please. Thank you.
So Ekika is a president.
मैम आई डोंट नो मैम. पहले तो वो थी पर अभी का मुझे पता नहीं है मैम.
अच्छा
जी. बट देयर सोसाइटी इज वेरी एक्टिव मैम.
हमारे लोगों ने ज्वाइन कर लिया. कैन वी स्टार्ट?
हाँ मैम, कई लोगों ने कर लिया हमारे यहाँ से मैम.
चलो ठीक है. चलो निशा शुरू करो.
So as Secretary of Logs, I welcome all the members who have joined from Lucknow Society as well as Jaunpur Society to this program, which is the Respectful Abortion Care. This is a FOXY initiative by Dr. Shanta. And this is an online training program. In our society, we have had one session previously, and this was planned again to cover up, to give an opportunity to all the members to be able to do it. So because of in wake of the new Amendment Act, MTP Amendment Act that has come, it's important that all of us attend it. And there will be 4 sessions. We are 4 master trainers who will be taking it. So I invite our president, Dr. Yashodhara Pradeep, to take up the first session of the program. Welcome, ma'am.
Thank you so much, Nisha. Dr. Nisha is a secretary of the Lucknow OBGYN Society. Dr. Rekha Sachan is Joint Secretary of the Lucknow OBGYN Society. And Dr. Vaishali is a Treasurer of the OBGYN Society. Okay. And this is just because Jaunpur has joined. So I thought that they should be knowing, because Lucknow people know about it. So it's a very good that Jaunpur has also joined. So may I share my slide?
Yes, ma'am.
Okay. Is it visible?
No, ma'am.
No, ma'am. Okay. So, but okay, share I did not click. Now is it visible?
Yes, ma'am.
Yes, ma'am. Yes.
Okay, thank you. So, as I said that Dr. Nisha has also said that this is a FOXY program, and this program is going to end on 30th of April. So it's an important program. I will request, because as a Dr. Ambar from Jaunpur has joined, and from the other members who are from Lucknow. So we are having 121 registrations, as I have been told. But the people who have joined is only 31. So I would request still, if anybody knows that whosoever is going to join, but registered and not able to join just now, because otherwise they will not be given a certificate that they have.
It's 16:45.
Joined the RAC, because this is a certificate course and this certificate will be useful for them. So I request that if anybody knows, they can do that. Okay, with this, I'm going to begin with this is a module 1 of the medical termination of pregnancy, Amendment 2021. So it is a very important document because there are a lot of changes which we were discussing for a long time, and we demanded and we were expecting. Everything is now being done. It has been gazetted and the law has been also gazetted. So we can now use it without any problem. Yeah. So objective of this module is evidence dissemination. That whatever we have amendment is being done, we have to now disseminate to all the members for the care of the members. So we should look at a closer look. What are the new laws and what are the changes in the laws? The rules have been done. So unsafe abortion in India, we all know that it is a 8% maternal deaths per year due to abortion. This is a third leading cause. So don't think that you are doing a safe abortion. That means everybody is doing a safe abortion. Still, it is a third leading cause of MMR, despite that MTP is being legalized in India in 1975. And the law has been made in 1957. 57, I suppose. So whom to say is a safe abortion, whom to say it is not a safe abortion. So there are two important criteria for this: is a method and the trained person. So if the methods are appropriate, is used for the that gestational age of termination, and it has been done by the trained person, then it will be safe. But if one of the criteria is not met, like in this, there is a only appropriate method is being used, or there's only a trained person is doing this thing, but they have not used the appropriate method, then it will not be a safe abortion. It will be less safe. If none of the criteria, neither the appropriate method nor the trained person is doing the abortion, then it will be unsafe abortion. So that is how we consider that this is an unsafe abortion, and we still see many problems coming to the tertiary care with the bowel perforation and bowel hanging out and everything. So is it mandated by the law, this safe and comprehensive care mandated by the law? We are going through one by one these amendment. So we have to see that what was the previous act and what the amendment was done. So a previous act was requirement of the opinion of one provider for MTP up to 12 weeks. But now it has been changed. Requirement for opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks of gestation. Second is requirement of opinion of two providers for MTP for 12 to 20 weeks. But now it is changed, the requirement of opinion of two RMPs for termination of pregnancy 20 to 24 weeks. So just remember that up to 20 weeks, only one RMP is required. After 20 weeks, the opinion of the two RMPs is required. But what this should be practiced and this should be available because this all has been done. So people don't have to travel to a big places because sub-centers or the centers are having only one medical practitioner. So all the potential, all the this outcome is increase the number of the facilities. So now we are going to increase, the government is going to increase the number of facilities, especially in the public sector, like PSCs eligible for service provider till 20 weeks. And the methods will be also supplied to them. Second is MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. Otherwise, only up to 20 weeks it was legalized. But what amendment has been done? Enhance the upper gestational limit from 20 to 24 weeks for special vulnerable categories of the women. And I will come after that. Who are the women who comes under the vulnerable category? And further enhancement of the birth defect not compatible with life on medical board consensus. So for the birth defect not compatible with life is no gestational age is being given, but there should record should go to the medical board and medical board should say whether it is feasible or it is not feasible. So the opinion of the medical boards after 24 weeks is needed, especially in case of where the birth defects are not compatible with life. So potential outcome is going to be this change is increase access for vulnerable women to safe and legal abortion services defined by rules committee include violence victim minor among others. So previous act said that the act had provision for termination of such pregnancy only up to 20 weeks. But now upper gestational limit does not apply in case of pregnancy with substantial fetal anomaly diagnosed by a medical board. Like anencephaly, we used to have, sometime the woman used to come at 34 weeks and we were not able to terminate, or 32 weeks or 28 weeks, we were not able to terminate just because the law said it is up to 20 weeks. We all know it is incompatible with life, it is non-compatible with life, so it should be terminated. So now our law says, but the records, if she's coming after 24 weeks, it should go to the medical board and the consensus for the medical board should come, and only then it can be terminated at any time of the gestational age, because we all know that this baby cannot survive. So potential outcome is of this act, change in the act is increase in the access to the safe and legal abortion services who often seek services late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, and thus reducing the unsafe abortion and court cases. Because in this case, sometimes people used to go to the court and that by the time the court decision has come, only then it was feasible to do the abortion in these cases. So it is also going to reduce the load of the court cases. Then there is a modification is related to the marital status. Somebody was asking about it. They can just understand and they can note it down. The condition of failure of contraceptive was applied for only married women or her husband. Now it says it is not necessary the woman is married. It is the contraceptive failure to be extended for any woman or her partner. So there's nothing like married or unmarried. Any woman who is having a contraceptive failure, then she can be given the MTP, she can go through the MTP without any problem. So what is the outcome is this, increased access to the safe and legal abortion, because these people used to go to the quacks or go to the places where the unsafe abortion, they are not safe for these MTPs to occur. And we used to have a lot of morbidity and mortality. So increase access to the safe and legal abortion for any woman, irrespective of the marriage age, especially with upcoming changes in legal age of the marriage, an important advancement for increasing the access to the safe abortion. We all know that government is going to increase the age of marriage age, 21 for girls and 23 for the boys, from 18 to 21 and 21 to 23. Then there is another clause is there, insertion of new clause for strengthening the privacy. That now, previously they said the medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under authority of the law. But now we say in 2021 that name and other participants of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being enforced. So you just cannot declare the name or any particulars to anybody except to the court, any authorized person who is coming from the law. So the outcome is going to be increase in privacy and confidentiality of the abortion seeker, increased demand, but need to safeguard the rights and dignity of a woman and provide respectful bias-free services, including counseling and contraception. So there were some salient features were there in which the law was silent. Now it is privatized, confidentiality and safety. So this confidentiality is very, very important part of the amendment. Women's name and other particulars of any woman seeking abortion to the confidential except to a person authorized in any law for the time being enforced. So it has to be confidential, your MTP, and it only is being disclosed to a person who is authorized in any law for the time being enforced. And the ground of failure of contraceptive has been extended to a woman and her partner. Marriage is not a criteria for getting the MTP services. So what are the rules under MTP amendment are there? There is a change in the group. Now this law 2021 says there is a special or vulnerable category of the woman eligible for extended gestational period termination of pregnancy from 20 to 24 weeks. Second is because in India, it is used registered medical practitioner instead of MBBS or a OBGYN. So we will come in the next slides who is a RMP and who can perform in the different gestational age these abortions, these MTPs. So then whose opinion is required for termination of pregnancy at different gestational age? They will also say that whether 1 or 2 is required. We have already said that there is only one practitioner opinion is required up to 20 weeks. And after 20 weeks, the opinion of 2 RMPs are required. If it is beyond 24 weeks, then it should go to medical board only in cases of substantial malformations of the fetus, which cannot survive. Powers and functions of the medical board, OBGYN. So you have to form a medical board, and this medical board, the state will form, not you have to form, the state will form. And it will be OBGYN, pediatrics, radiology whenever available, or if they want any other person, they can also be included into it. So what are the special category of the women, of the vulnerable woman who is being given the extension of the MTP from gestational age 20 weeks to 24 weeks. So it is a survivor of the sexual assault, rape or incest. Women with pregnancy in humanitarian settings, disaster and or emergency situation are declared by the government. Like we have seen, there was a lockdown. So in this case, many women who have grown from 18 to 20 or 20 to 22 weeks, so they should be they can be terminated pregnancy up to 24 weeks. Change of marital status during the ongoing pregnancy, like the woman may be divorced or got a widowhood. In that case, if she does not want to continue the pregnancy up to 24 weeks, it can be terminated without any problem. Women with physical disabilities, major disabilities as per criteria under the Disability Act, because they are not getting the chance to come to the person for all these things. So they have been given the special category or the vulnerable group of the woman. Mentally ill women, including mental retardation, minors, and the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from physical or mental abnormalities to be seriously handicapped. So these are the 7 are the categories, vulnerable categories, they have been included and they have been given a chance to terminate their pregnancy up to 24 weeks. But here, 20 to 24 weeks, you will require the opinion of 2 RMPs. Now, who is RMP? So RMP defined in the old act as MBBS or more with any. So you have to be MBBS. So medical practice assisted in 25 cases of MTP, of which at least 5 done independently in the hospital. Medical practitioner who has completed 6 months of the house surgery in the OBGYN. Medical practitioner who holds a postgraduate degree or diploma in OBGYN. Medical practitioner who has experience of at least 1 year in the practice of OBGYN. So up to 20 weeks, 1 RMP opinion is required. 20 to 24 weeks, 2 opinion of 2 RMPs are required, and medical board is required whenever the pregnancy is beyond 24 weeks. And the special category that we have the fetal malformations having a substantial risk not to survive, or they are going to have a major disabilities. So under 2021, the amendment says that additional category of the provider has been added. Till now we had only 4, but now we are having 5. So there is a one, if the termination of the pregnancy is up to 9 weeks with medical method. So RMP with experience in the practice of OBGYN at any hospital for 3 months. So any MBBS person who is having experience working in any OBGYN hospital for 3 months, or training with performance of 10 cases of MTP by medical method of abortion under supervision of a RMP who is already registered medical practitioner in a hospital established or maintained or training institute proved for this purpose by the government. So any person who is having the 3 months experience or have done 10 cases of MTP and the medical method, because we know that medical method is used up to 9 weeks of pregnancy, and supervision of this under any supervision, and it is only 1 RMP is required. You all know that. So it is only up to 9 weeks. This RMP can have the can do the MTP till up to 9 weeks. Now there is a till 9 weeks. So every person, yes. So this was the another category which was added. So these are the 5 categories. Till now we had 4 categories. Now we are having 5 categories. So till 9 weeks, all 5 categories of the RMPs are eligible to do any MTP till 9 weeks only. So one which has been added now is experience at any hospital 3 months, or she has done the 10 cases of MTP by medical method under the supervision of RMP in a hospital or in a training center which has been approved by the government. Second category of the registered medical practitioner is a practitioner who assisted RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently. So this is the second category of the RMP. The third category is any OBGYN whose postgraduate diploma or degree can do the MTP. Fourth is any practitioner who has completed 6 months of the house surgery in the obstetrics and gynecology. Any practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. This is all MBBS who have at least 1 year in the practice of OBGYN. And till 9 weeks, only 1 RMP is required. Till 12 weeks. You can see there are only 4 categories of the RMPs are there, which can do the MTPs. So category 1 of the RMP is who has assisted 25 cases of the MTP and 5 has been done independently. Who is having a postgraduate degree or diploma in OBGYN. There's who is having a house surgery in the 6 months. She has done the house surgeonship for 6 months in the department of OBGYN. Or she has done 1 year in practice of OBGYN in any hospital, who is running a OBGYN hospital, and she has worked for 1 year. So it is also up to 12 weeks, only one RMP is required. It could be anyone from these 4 categories. Beyond 12 weeks till 20 weeks, still there is only one RMP is required, but the category now from 5, it is only 3. Any person who is degree or diploma, or she has done the 6 months house job in the OBGYN, or she has worked in any hospital who is having OBGYN practice, and she has worked for 1 year in the practice of OBGYN. So this is about the norms of the RMP whose opinion is required for termination of pregnancy at different gestational age. For only one RMP is required. So you have seen from 5, we have come to 3 as the gestational age has increased. The RMP definition is also been changed. Beyond 20 weeks till 24 weeks, experience and training requirement for the RMP is a practitioner who holds a OBGYN degree or diploma, or she has done a 6 months of house surgery in the OBGYN, or she has had the experience of 1 year in the practice of OBGYN in any hospital. But we know that 20 to 24 weeks will require the opinion of 2 RMPs. Beyond 24 weeks, experience and training of requirement is we have to go to the medical board. An opinion of the medical board is required for the termination of procedure when advised by the medical board is carried out with all safety precautions along with the appropriate counseling at an approved place. So this is all that medical board should be there, and it should be performed with safety precaution along with the appropriate counseling at an approved place. And there's only 2 categories are left who can perform the MTP beyond 24 weeks. One who is having a degree of OBGYN in the degree or diploma in the OBGYN, and second who has done 1 year. The 6 months house job person can also not do it. But a person who has done 1 year in OBGYN or in any hospital who is recognized for OBGYN can also be registered for beyond 24 weeks. So rules for MTP Amendment Act is composition of the medical board. So when we are doing a MTP beyond 24 weeks, we know that we require a medical board, and gynecologist is must, pediatrician is also there, and radiologist and sonologist. These are the 3 major people should be there. But if we want, in a case, certain cases, we want to include some other specialists, we can also do that. So under the MTP Amendment Act, 3 powers of the medical, the powers of, what are the powers of the medical board? Is to allow or deny termination of pregnancy beyond 24 weeks of the gestation. So it is not necessary that this medical board is going to say yes. It can also say no, only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age, and whether the fetus malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So as I said, co-opt other specialties in the board and ask for additional investigation if required for deciding on the termination. So you can co-opt other specialists also. So FOXI with ministry guidelines and WHO support as a part of RAC can operationalize and host the medical board information on the website. So FOXI has given the option to the Ministry of Health that with the support of WHO, they can also put the name of the medical board on the website of the FOXI. What are the functions of the medical board? So examine the woman and her reports, who would approach for medical termination of pregnancy, or who is being referred by the RMP for this termination of pregnancy. Provide the opinion of medical boards in Form D. So they have to provide the information Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving. So there's a time frame is also there that this medical board has to reply within 3 days of receiving the request for medical termination of pregnancy. To ensure that termination procedure, when advised by the medical board that MTP is required, it should be carried out within 5 days of the receipt of the request for medical termination of the pregnancy. So the procedure should not go beyond 8 weeks. Once she has the papers have reached to the medical board, within 3 days they have to give yes or no on the Form D. and after 5 days, it has to be carried out. So FOXI is playing an important role to play in ensuring there are functional medical boards in every state as it is stated in MTP Amendment Act 2021. So this is a registration and pre-test, post-test feedback you have already done. When you will finish this, you will have a pop-up, you will do a post-test and give a feedback, and then you will be given a certificate. So all the participants who are doing this training course, to get a certificate, they have to see there is a pop-out. Once they are going to finish, there will be pop-outs and there will be post-test and feedback. And once they submit that, only then the certificate will be awarded to the participants. So thank you so much for this. And abortion is illegal. Let us make safe and respectful. Samarth Bharat, Sampurna Bharat, Jai Hind. Thank you so much.
Thank you so much, ma'am. There are a few questions in the chat box. So you can take them. I'll read them out for you. Who will make the medical board?
Who will
make the medical board?
It is the state who is going to, state can give the responsibility to the district hospitals or the CMO. So state will give responsibility to the CMO, and CMO then give this responsibility to the medical colleges or to the district hospital as and when the things are required or the things are available in that city or town. Because everything is being done to facilitate the MTP, so the person is not going to move or go through long distances.
Right. And another one is how to approach the medical board.
I'm sure that this has to be referred by the practitioner, because we are teaching not the public.
Right.
Medical officers or to all the members of the FOXI. So once the person is going to approach to you and you see that it is beyond 24 weeks and she's having a substantial risk, so you send it to the medical board. So you should be aware of the medical board which is available in your area, your district, and you'll send the papers and request that it should come. And medical board should be given instruction that they have to send it back within 3 days on the Form D. And then you have to carry out the termination within 5 days of this.
So another question is, which CMO office in Lucknow, MTP office, whether patient will go or doctors will go?
I'm sure that because this has been by the WHO, this is from the Ministry of Health. So Ministry of Health must be delineating their orders to the state authorities and to the Directorate of the Health, because it will come to a state and then it will go to the Directorate of the Health and then it will go to the CMO, and then CMO will do the things. So many society, and let me complete this, that many district boards are already been there, because all of you must be remembering that there was a case when the ligation was done. There's so many deaths were there. At that time, we have also made district medical boards. So probably those medical boards will be given an additional responsibility of this. Although in that medical board, the DM was also the part of it. I do not know whether here they are also going to make a DM for the part of it or not. But already their district, in the district, medical boards are existing. You can put a question to the CMO that I have got such and such patient, how to do this medical board. So it should be.
Yeah, that's right. That if a patient comes and you think that patient has to be managed through the medical board, then you talk to the CMO and then they can direct you.
So in case the CMO has not taken the action by this time, now
then they will take
be activated and you'll do it. That is my perception.
Yeah, that's how it is, ma'am. Because wherever there is already existing, they will refer to those people. If it is not, they will make it or do the necessary.
I know that there's a boards are existing for the
most of, yeah. Okay, so the next question is, if the patient comes late, like around 23 weeks and high risk for trisomy 21 in quadruple test, invasive testing is positive for trisomy 21, then what will be procedure for her?
This is a definite diagnosis of the trisomy 21. So you have to counsel the woman, because see, many patients I have come across who had the IVF pregnancies. They say, I've got something better with something than nothing. And they also see that what are the how much the babies is involved, because trisomy 21 from severe to the mild can happen. So some babies can have almost normal life, they can go to even school, and they can have some abilities by which they can be trained. So you have to sit with the couple and tell them that what it, but there may be some people who are already having the 4, it was the unintended pregnancies. Now it has come to this, they may say, I want to termination. So if there is a possibility is there that you can find it out that this baby is having severe heart defect also.
So ma'am, she has said that if she wants, so if the patient has decided, then because it is less
if
than
patient has
24
decided, she
weeks.
can. If patient
Yeah.
has decided, she can.
So less than 24 है, 23 weeks आप बोल रहे हैं, तो easily two with the consent of two medical officers.
Even she can go beyond 24 weeks also, because
Yeah.
there's a
there the board will be
trisomy
required.
21.
Yeah, but up to 24, even with two people, it can be taken.
So now the medical board will decide to say yes or no. If she's beyond 24 weeks, the medical board will decide.
Yeah.
So they will probably counsel the couple and whatever is this, and they will see. And here the cooperation of the other specialties are needed, maybe the pediatric cardiologist or pediatric or something else, and they need further investigation, they can also suggest, because here there's no upper limit. So if it still is going to take some time, they can take, because further investigation can also be done in this case.
Yeah, so thank you, ma'am. That's all from the questions. So I think we can take up the next. Should I start off?
So thank you so much. Is there any other question? Then I can say, otherwise.
We finished with what was there in the chat box.
Yeah. Thank you so much.
So you can keep writing still, it comes to your mind, and it will be answered through the chat box, or when we have a break between two sessions, when we just, yeah. So I think, thank you, Dr. Yashodhara. I'll take up my talk, the next one, just sharing the screen. I hope I'm visible and audible too. My slides are visible. Okay, so basically, after having heard about all the changes in the MTP Act from Dr. Yashodhara, this session is talking about how do we provide safe abortion to our women, what are the updates in the technology, and also what are the other important things that we should take care of while providing these services. So most of us know how to deal with abortions as such, but we'll just try to have an overview of the existing guidelines, the pre-abortion assessment, kind of a revision, but adding few important points, medical methods that are available, and the surgical methods that are available. These are some of the literature sources you can find on safe abortion. WHO has been coming out with a lot of these handbooks and on safe abortion, technical and policy guidance, and the medical management separate one, and safe abortion care and post-abortion contraception. So if anytime you all feel, you can find them on the net, they are easily available. WHO has been publishing since 2012 different guidelines whenever there have been changes. So from 2012, then there was this handbook in 2014, and then 15 also about the how to provide safe abortion care and the post-abortion contraception. Then the main guidelines that we have of the medical methods is in 2018, and in 19 we have this consolidated guidelines on self-care intervention for health. So these are basically the references from which this has been taken. As you have heard that the law has changed on 25th of March, and then the rules have also changed. That's how the details were being shared by Dr. Yashodhara in September 2021. So we are all set to take over and practice through this new amended MTP law in India. All the guidelines have 3 key areas in management of abortion safely. Of course, whenever a patient comes, it's the pre-abortion care, then the abortion care methods, and then the aftercare and the follow-up, which includes post-abortion contraception and counseling. So as you can see, we always take a medical history, a physical examination, and then we have to see which investigations are required, really required for all of, we'll be talking about this, and then the contraceptive options. So this is how we have to go through. These are the important components of the safe abortion care. So for the pre-abortion assessment and the counseling, we have to take a detailed history, physical examination, and the pelvic examination. Then talking about the lab reports, I'll just come to that. So why history taking is important and examination? History taking mainly to see if there are any risk factors in this woman. Does she have any medical disorders or anything for which you might have to, it might be better to send her to a higher center. Examination also to pick up those high risk factors, and pelvic examination in particular to know the correlate the period of gestation that is coming through the last menstrual period and what is coming through the examination, so that if there is any discrepancy, please mute all the participants. Back-end team. So now talking about the gestational age determination by LMP, all of us know it right from the beginning of the MBBS curriculum. When we go to OBG, we learn this, how to calculate the period of gestation through the LMP. So asking the LMP is important and then calculating, but we all know that many women in India still, they may not be able to tell you the exact last menstrual exact date, and you might have to correlate it with some festivals or some important events. But therefore, that is another reason that it's very important to do a pelvic examination and assess the clinical size of the pregnancy. And we know that it's after 4 weeks that you are able to see it. In fact, from 6 weeks onwards, you are able to assess the enlargement in the uterine size. And up to 12 weeks, it will still be a pelvic organ. And after 12, it will become an abdominal one. 16 weeks, it will be somewhere midway between the umbilicus and the pubic symphysis. And at 20 weeks, it will reach the umbilicus. So there are certain conditions in which there might be a limitation to the dating by uterine size on clinical, like if the patient has some uterine malformation or the patient has a uterine fibroid. Suppose there is a twin pregnancy, if the uterus is markedly retroverted, if there is obesity, or in case there is an abnormality like the molar pregnancy. So in these conditions, the size of the uterus and the gestational age may not match completely. Size may be smaller or bigger. And like there are certain conditions in which the size will be smaller. Maybe she's not pregnant, but it's a false pregnancy test, or she hasn't done the pregnancy test, or there is an inaccurate menstrual dating, or there is an ectopic pregnancy, or there is a spontaneous or a missed abortion which has already happened. So you have to keep in mind if the size is smaller, these are the things, and you have to confirm them. Similarly, the uterus may be larger than the expected, which will be again because of incorrect dating or twin pregnancy or triplet pregnancy, presence of fibroids or a molar pregnancy, in which condition most of the times it is bigger than the period of gestation. So importance of taking the history and then the examination to find the correlation between the gestational age and the clinical findings. If it is not so, then you will need an ultrasonography most of the times to confirm and then take your decision, because your method of termination will change accordingly. Now talking about the pre-abortion investigation. So routine lab test is not a prerequisite. So that's what is important to tell, that if the pregnancy is already confirmed, the size is matching the period of gestation, you on this clinical basis, you can give the medical method of abortion. But if there are discrepancies, if the pregnancy, you will need some tests. So a pregnancy test, if the pregnancy is unconfirmed, hemoglobin, if the patient is looking pale and you suspect anemia, RH testing, if you have the facility of giving RH antibody, you must do the RH test so that you can give it the same day when you are giving the MTP, the medical method. HIV testing and counseling should be, if you have the testing facility, you should do that. And STI screening also, because if you do the examination and you find there is dirty discharge, then simultaneously, if you have the facility, take the sample for that also. And other laboratory tests depending upon the medical history, which I mentioned right in the beginning. If she's a high risk case, maybe if your center is not well equipped to handle that, better to send her to the higher center. Ultrasound is not necessary unless to diagnose the pregnancy not certain, or suspecting ectopic or missed abortion or molar pregnancy or multiple pregnancy. So in all these conditions, you will need a scan to be done. So once you have done this, then you have to talk to the patient. You have to ask, what are her thoughts about terminating, just to know that she be sure that really she wants it. It's not under some pressure that she's come for this abortion. So you should be sure that she actually wants it. You should try and understand the reasons for terminating and actually to document them also, so that it fits into your MTP Act. So, and then tell her that if the abortion is to be done, it is better to get it done early in the early gestation, and the importance of a trained provider performing the procedure for safety, so that she doesn't go here and there. And available methods that are there, you should tell to her about them, and also the risks and the warning signs that are associated with each method. You have to talk to her about contraception after the procedure. I mean, counsel her before doing it, telling her the reason for the same, that patient may get pregnant soon after this abortion also, because the ovulation may happen within 14 days. So that is the basis for counseling her for contraception post-abortion. Resumption of her normal activities, including sexual intercourse, when it will be possible, you have to tell about that, and follow-up care when she has to. So all this has to be told to her in the beginning when you're doing the pre-abortion counseling. And the documentation requires the informed written consent and the decision to accept post-abortion contraceptive. But mind it that even if she does not accept a post-abortion contraceptive, doesn't mean that you will not give her the safe abortion services. Now coming to the methods that are available. So as per WHO, it's less than 12 weeks, the global recommendation of giving mifepristone with misoprostol or misoprostol alone, or vacuum aspiration. These are the options. After 12 weeks, of course, you go for the mifepristone with misoprostol or misoprostol alone, or dilatation and evacuation, not directly, but after the induction of abortion only. Government of India recommends that medical method should be used only up till 9 weeks. That's a slight difference that we'll have to remember. And in the up to 7 weeks and 7 to 9 weeks also, there's a slight difference in the dose of the misoprostol. I'll just come to that. So in the first trimester, we understand that we can give medical methods as well as surgical methods. Medical are the drugs we'll be talking about, and the surgical is either a manual vacuum aspiration or electric vacuum aspiration. So manual electric is where with the suction machine that you do, and manual is when you use the MVS syringe. So depending upon the electricity availability, you choose either of them. And the medical methods I'll just talk about here. So because the medical methods are mainly based on the mifepristone and the misoprostol drugs, so let's know a little more about them. Mifepristone is an anti-progestin which inhibits the action of progesterone. So it interferes with the continuation of pregnancy. So when you give mifepristone tablet orally, 200 milligrams single dose is given, it will lead to usually the kind of not IUD, we'll call it, will be leading to the stoppage of the cardiac activity. And some women may expel just with this single tablet also. And we add mifepristone, the misoprostol, after 1 to 2 days, that is 24 to 48 hours. In the standard regime, we are writing 48 hours, and that causes the cervical softening, uterine contractions, and expulsion of the products of conception. So basically, mifepristone interferes with the continuation of pregnancy, leads to the intrauterine demise, and the expulsion part is taken care of by the misoprostol. So the mifepristone dose is 200 milligrams. And then if the patient is Rh negative, you have to give anti-D simultaneously, which is 50 microgram. You can give it on the day 1 itself. And mifepristone, after the mifepristone administration, day 3, you have to give misoprostol. And this is what I was saying, up to 7 weeks, they say you give 400 micrograms should be if enough. You can give it sublingual, buccal, vaginal, or oral. And from 7 to 9 weeks, it's better to give a higher dose, which is 800 microgram. But here you do not give oral, maybe there will be more of nausea, vomiting. And so only the sublingual, buccal, or vaginal routes are recommended after between 7 to 9 weeks. In addition, you will need analgesics, antiemetics, and contraception we have talked about, so that will be added. Now, talking about after you have done that, patient, you have to tell that she will expel, there will be bleeding, there will be some pain. That's why you're giving the painkiller, and gradually the bleeding will stop after, say, 7 to 10 days. So usually after 14 days, there should not be any bleeding. If it continues, she needs to come back to you. So, or you can call her for a confirmation visit, or if contraception, she has not agreed in this visit, then she can come after 14 days. But it's not a mandatory thing to come after 14 days if everything goes normal. Now, about the routes, I was just saying that after up to 7 weeks, you can give any route, but from 7 to 9, we don't give oral routes because of the higher risk of diarrhea, nausea, fever, and chills. Now, the buccal sublingual, maybe we'll just show you a picture so that you can understand. In the buccal, pills are placed between the gums and the cheek, and it is swallowed after 30 minutes. It leads to more fever and chills than as compared with the vaginal. Sublingual is putting it under the tongue and swallowing after 30 minutes. Here also there may be increased fever, chills, diarrhea, and vomiting compared to vaginal route. But only thing is that these options may be more acceptable to the woman as compared to vaginal. But if she comes to you and she accepts, it's nice to put it vaginal because the lowest rates of side effects are with the vaginal tablets. So this picture shows what is buccal. It is between the gums and the cheek actually, and the sublingual is under the tongue, as you can see in the picture here. So that was below 12 weeks, as we said, 200 milligram mifepristone followed by 800 microgram misoprostol. So that's if you're giving only misoprostol, that's an alternate method. There you have to give 800 micrograms of misoprostol only. Vaginal bleeding for 2 weeks is normal, as I said before, and such bleeding sometimes can last a little longer. But if it happens, you have to tell the patient that if the bleeding continues after 2 weeks, she must come back so that you evaluate, is it an incomplete abortion? The chances are very less, but few patients will be there who will have it like that. Now, services should be available at the primary care level, ideally with referral systems in place for all required higher level care. Additional services may need to be provided to individuals seeking medical abortion, because we have learned that apart from giving the abortion, wherever you give abortion services, simultaneously you should have counseling and testing for STIs. You should have abuse support services, psychological or social services, because these women, if they are coming for abortion, not necessarily that it is a normal married life and then they are coming, they may be rape victims, they may be other people who have some other problems. So there should be the abortion services should be coupled with those services also. Other specialist health or medical services, suppose you find somebody has a high blood pressure or she has some other medical disorder which you diagnose, so you should be able to have a connection with higher centers where you can send them. Simultaneously, you will have to provide iron tablets for anemia and any necessary pain medications and emotional support, of course, throughout the procedure. For the follow-up, routine follow-up not necessary. I have already told you that follow-up visit 7 to 14 days after procedure may be provided if the contraception counseling has been inadequate or the patient has not taken up anything, or if she just wants to visit you in case she has any trouble, she must come back. When she comes for this follow-up visit, assess her recovery, ask for any signs or symptoms of ongoing pregnancy, review any available medical records and referral documents, ask about any symptoms, because sometimes you might have referred her to the higher center and she might have received the services there, but for follow-up, they tell her that you go to your nearby doctor only. So she may come to you. So in that case, you should read her medical records in details, ask about any symptoms that are experienced since the procedure, and you do a focused physical examination depending upon the complaints. So if she's bleeding, obviously you will have to do a per speculum and a PV examination. And if you suspect incomplete or is open or something, you will have to further treat that also. Completion procedure will be required. Assess her fertility goals and need for contraceptive services if not provided earlier. So to summarize this, day 1 is physical and pelvic examination, confirming the eligibility, giving her mifepristone and anti-D. Then you have to tell her to return for the misoprostol after 2 weeks. Take her contact address and phone number, and also give her the contact number and the phone number of contact address and the phone number of the facility, so that if there is any emergency, she bleeds very heavily or something, she can come back. Record her experience of any side effect, and as I said earlier, 3% women may expel completely with the first dose, that is the mifepristone alone. But the schedule has to be completed. You still have to give misoprostol on the 3rd day, and then tell her that the bleeding may continue for a few more days. So that's an important point. 2nd day when she comes, you give misoprostol 400 microgram, that is up to 7 weeks. Simultaneously, you give ibuprofen as a painkiller. Talk to her about the contraceptive choices and tell her that the mean bleeding time is 8 to 13 days. Tell her about the side effects also, the nausea, vomiting, diarrhea, fever, dizziness, and what medication she should take in case she has fever. And tell her she can report back in case of excessive bleeding, pain, or fever. And if there is no bleeding in 24 hours after misoprostol, then also she should come back. And then you can think about giving 1 more dose of misoprostol. So 75% of the women will abort within 4 to 6 hours after the misoprostol administration. So that's the basis on which we say that if she does not abort in 24 hours or there's no bleeding, she should come back. And then the follow-up visit, as we said, not necessary for all, but for reassurance, for emotional support, for completing your contraceptive advice, she should come back. Or if she has any problem, then she should come anytime when she has the problem. And also, if she should report back if there are no periods within 6 weeks of completion of abortion. That's very important. So that is another indication for coming back. And ultrasound only if the examination does not confirm the completion of procedure. Side effects we have mentioned, and pain, of course, is the most common, but we have to tell her that pain will be there. It will happen whether you take the medical method. In the surgical method, of course, we may give some anesthesia, the local or paracervical. So you have to give a verbal support and counsel her. You have to add an analgesic also. And if there is persistent pain with failure to respond to these drugs, then she should come back. And you also should be very sure that it is not an ectopic through your examination, so that this does not happen after you have given the medication. Nausea and vomiting mostly will be self-limiting, so you can just reassure them. You can give some antiemetic also. Diarrhea also will be minimal, mostly self-limiting. And infection, the medication or the safe abortion services will not cause it. But if she is already having some infection, that you must see, and you must treat it or take a sample. As we said, STI testing should be done if there is already some symptom, and start antibiotics also. Now, if there is a failure, patient comes back, there is some bleeding continuing, so you can offer either of the two, whether surgical abortion, that is mostly the better method, because patient would not like to come again and again. But though, as per the guidelines, you can repeat the medical method also if there is absolute failure. But if it is incomplete, then you just see how much is the bleeding. If the bleeding is just minimal, you can, it's okay. But if the bleeding is heavy, you may repeat a misoprostol, or you can do a surgical evacuation also. Basically, the purpose is to ensure that abortion is complete, either through another tablet of misoprostol or surgical evacuation, if that we do when the bleeding is heavy, to relieve her completely and not let her go into shock or have anemia due to that. So in case of excessive bleeding, that's how we have to evaluate and then see when to take the decision about surgical evacuation or give another. I think this is a little bit of repetition on that only. Now, recording and reporting, this is very important. Since this comes under the purview of MTP Act, that's very important for all of you to remember that even if you are giving medical method of abortion, it comes under the purview of MTP Act. Though the drugs are available over the counter, still it should be documented, and similar to the VA procedure. So a Form C, which is the consent form, should be filled. Form 1, which is the RMP opinion, that is the decision taken for MTP, should be there. Then there is a Form 2, which is a monthly reporting form, which has to be sent to the district authority. So you as an RMP or a medical practitioner, you have to maintain your record of the number of MTPs you do in a month, and you have to send that monthly report to the district authorities. And you should have your admission register for all the patients who are admitted. So that also should have the cases which are admitted for this purpose. So the surgical methods, will be very short. Surgical methods in the first trimester, vacuum aspiration is the recommended technique of surgical abortion up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. Procedure should not be routinely completed by sharp curette. So there's no need to add sharp curettage. You should do the suction evacuation either through the suction machine or through the manual vacuum aspiration syringe. So this aspiration syringe, you all must have seen the MVA syringe, 60 ml capacity, and there is an aspirator which is attached to the cannula. Cannula size will be according to the size of the uterus, like we say from 4 mm to 12 mm. So suppose 8-week size, then you use actually a slightly smaller size. You can put 8 mm cannula for 8 weeks and 10 mm for 10 weeks. That was correct. Okay. So this, all right. Okay. And if you're using the surgical, the electric vacuum aspiration, then this will be the suction machine, and with the suction tubing, you attach the Cummins cannula, again the suction evacuation. So the same cannula can be used for both MVA or EVA. Cervical priming, that is giving a tablet of misoprostol before the surgical evacuation. It may be considered for women with pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. So in surgical abortion in the first trimester, you can give oral mifepristone 200 milligram or 400 microgram misoprostol, which can be given sublingually or vaginally. So when you give vaginally, you give it 2 to 3 vaginally and sublingually 2 to 3 hours prior to the procedure. You can even use a laminaria placed intracervically 6 to 24 hours prior to the procedure. Pain management, we have already talked, both pharmacological, non-pharmacological, reassurance, counseling, verbal method. And yeah. Pharmacological, we have talked about you can give anxiolytics, but mostly during the surgical method, you can give a diazepam 10 milligram orally, or you can, we have talked about analgesics, that is ibuprofen or NSAID 400 to 800 milligram 1 hour prior to the procedure. And duration of effect will be 4 to 6 hours. If you're giving the local anesthesia, then you use 10 ml of 1% lignocaine. So there may be some side effects like dizziness and the gastritis, seizures, very, very rare. Do they have put it, but rarely seen. With analgesic ibuprofen given 4 to 6 hours, there may be some gastritis, but this usually works well. Actually, you give a tablet before the procedure and it works well. So some patients may need more of this local anesthesia or diazepam, but otherwise, even a single tablet before the procedure can help. I don't think I should, okay, maybe in very short, the procedure of MVA. The important thing is preparing the instrument. You have to close the valve buttons and you have to create the vacuum, that is charging of the MVA syringe, and then ensure that the painkiller has been given to the patient and ask her to empty the bladder and then lie down. And then you perform the procedure under all aseptic precautions. So you clean the area, cervix and the vagina, administer the paracervical block, and then dilate the cervix and then insert the cannula. And then start the suction of the uterine contents. It keeps coming. So while the aspiration is being done, you just gently rotate the syringe, and there is, once it gets filled up, you can empty it and put it back again. But by and large, the first trimester abortions will be mostly done in one go only. Only if the uterine size is more than, say, 8 weeks, then you will need to empty it and use it again. Signs that the uterus is empty will be the presence of red or pink foam without the tissue passing through the. So you can see that nothing more is coming out. There is a gritty sensation and the cervix is gripping over the cannula. These are the signs that the cavity has been emptied. And then you take the tissue, put it through a strainer and see that the products of conception are there. And then give the contraception, because IUCD can be inserted simultaneously. If she has asked for sterilization, you can do the lab ligation at the same time. So, and instrument processing with 0.5% chlorine solution, disinfection and everything else has to be done. Post-procedure, monitor her for any complications and provide management as needed. She may leave the facility when she's stable, she can walk, she can have something orally. So when she's comfortable, you send her, but see to it that there is someone to accompany her and document all the procedure that you have done. And if there were any adverse events, they should also be mentioned in the record book. Post-abortion, if there is incomplete abortion, infection, bleeding, or ongoing pregnancy, they all have to be taken care of, just like medical method of abortion. And contraceptive information and the contraceptive counseling and methods are very important component of safe abortion services. And other sexual and reproductive health needs are also to be taken care of. And no routine follow-up unless misoprostol alone. So it's only with the misoprostol alone regime that they say all women have to come back after 14 days. So to summarize, India has made historic progress in improving the access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. That is how we talk to the woman, how we take care of her, how is your facility, privacy, and the way you talk to her. All these things are very important. Every client, whether in the public or the private sector, should have the opportunity to information, education, and all your setup should be equipped with proper information on contraception and counseling also. So again, telling you that the certificate will be awarded after you have completed this training. Towards the end of it, either a link will be provided, or before leaving, when you click leave, there will be a pop-up of feedback, post-test and feedback. So when you do that post-test and feedback, then only the certificate will come to you. So please stay back till the end of the training and do the post-test and feedback. When you have submitted that, then only the certificate will come to you.
Thank you very much, Nisha ma'am, for such an elaborate talk. We have 2 questions. Is the USG report not necessary for this before giving this doing MBA, MMA or the surgical method?
Yeah, so that's what we were highlighting again and again. It's not mandatory as a routine. If clinical features and your period of gestation, they correlate well, then you can just go ahead without doing a sonography. So this question comes to everybody's mind. I have myself been questioning this a number of times, because you feel if there is a molar or if there is this thing. So that's what they say, that if you suspect clinically, then you go for it. So there is a lot of emphasis on your clinical assessment.
Another question is, sometimes patients keep doing UPT at home. How to counsel them?
I mean, keep doing UPT is okay. If they will miss the period, they will have to. It is good that they are aware that it might be pregnancy, and we want them to come in the earlier pregnancy.
No, I think she's asking like after taking a pill, how many, till how many days the UPT will become negative or something like that they want to ask?
I don't think they should be following this with UPT, whether it is complete or not. That's not at all there. We have to counsel them that we are giving them medical method. And as I said, that the bleeding will continue for this many days. If it is too heavy, they should come back. If not, then it is accepted that it is complete. But if they wish to come for a reassurance as a follow-up visit, they can come after 2 weeks. But routine follow-up also in the new guideline is not a recommendation. So only if they feel that they have a problem, they should come back. Or if they are not assured, then they should come back at 14 days. But
So
don't do UPT for that.
Yeah, if the patient is doing UPT, at least they should wait for 15 days. And then
see, I think if this comes to our knowledge that they are doing this to confirm whether it is complete, or we have to tell them that this is not the method of confirming this, and there is no need to do this unnecessarily. They will get, because it takes it takes on an average 8 weeks to for this thing to go away, the HCG levels, in the serum. So urine also, they may keep coming unnecessarily. They will be troubled with it. Right?
I think that's all.
Yeah. Let me congratulate that there is a 76 people have joined.
Yes, ma'am.
So it is a number
Increase.
joining with the Lucknow Society and with the Jaunpur Society. We have really increased our participants, and that is going to improve. I just was hearing few questions. So I just want to add this, that many things we are doing which are not in the protocol because of the apprehension and so many other things. Like people say ultrasound is must. People say that a follow-up should be done with the UPT. So let me say this is all your apprehension. If you have done a good job, this is all not required. And only in the cases where there is a problem like previous 2 section, then you are supposed to do a ultrasound, because you have to rule out that it is not a scar pregnancy. If it is a previous 1 section, maybe you want to do it because you want to rule out a scar pregnancy, which is high. But here we are not discussing all this. We are discussing only the points which have been required for any average RMP. Because this will not be done by any average person. If it is a previous 2 section or previous 1 section, because if something happens, then it is going to be a problem.
That's true.
It is better to choose your clients accordingly.
Judiciously.
One more question is there. If the age is less than 18 years, I'm not sure what she wants to ask. Like if the age is less than 18 years, whether we can give her medical abortion or whether I'm not sure. The question is if age is less than 18 years.
I suppose the person wants to know. If I'm sure, if it is wrong, then a person can add into it that if anybody comes for the MTP who is less than 18 years of age, what to do? Is it right?
Yeah, I think that is the question. Yeah,
that's the question.
Yeah. So it is. We have already said that if the age is less than 18, she's a minor. So there is another act, POXO, and POXO we have to follow the POXO. So we have to do MTP. We do not want. We should not. We do not. We should not. Must not deny the MTP, but we should do. This is probably has been also covered in the WHO tools. WHO tools, it will also be covered. You have to do MTP, but at the same time, you have to report to the whatever POXO Act says. You have to follow the POXO Act also.
So we can go ahead for the next session.
Yeah, is it all right? The answer is yes.
Important thing is that we do not have to deny, for these safe abortion
Because
service.
we have already said that for the vulnerable group, we have extended it till 24
Yes.
and
Yes.
minor comes into the vulnerable group, and less than 18 is a minor.
Vaishali, you will be taking the next.
Yes, he said Rupali Gupta was there. She said yes, she meant that only. Yes, ma'am. Thank you, ma'am. Yes, thank you, Rupali. So the next participant, next talk is of Dr. Vaishali, the WHO Saver Kit tool, Saver Tool Kit.
So good afternoon, everyone. As we all know, compassion, kindness, and respect are the very essence of dignified care. And we must make sure that these principles are taken care when we take care of our patients. So our third module is about, I'm visible? Ma'am, you have to.
Yeah, Vaishali, we can see your slides.
Okay. Second. Share my slides. The third module is about the saver. You're able to see my slides?
Vaishali, ye end of slide show hai. Maybe you were on the last slide. So you
Okay.
Yeah.
Okay.
And then put a play.
Yeah, sure. So it is basically Saver Toolkit of WHO, which is about the safe abortion values, evidence, right, and respect. So this module aims to define the respectful abortion care with as per the WHO standards, and then we'll be highlighting how norms and stigma affect services, and will provide WHO saver resources for respectable abortion care. So now the momentum has already been created. Since the law has changed, rules have come. What all we need is the dissemination of this law and the rules. And the FOXY being the largest provider base for abortion care, and with the COVID, now the facility of online training is possible. So we are expecting that this respectful abortion care can reach to all providers, and will also be updated about this. Medical method of abortion has enabled us for an early and safe abortion techniques, and it also has ensured that no PCP-NDT conflation is added to it. So what is important is the patient safety, respect, and quality, and we have an important role to play for it. So what the respectful abortion care is basically, as per WHO, it refers to the care that maintains safety, dignity, confidentiality. It ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. In simpler terms, respectful care means you as a provider or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. If you ever feel that something isn't right, speak up. As health professional, it is our duty to listen and support. Communication is the key of all the treatments. So what are the norms and stigma which are there for the abortion care? It's the physical abuse, which can be slapping or intimidating physically, verbal abuse.
Madam, sorry to interrupt you, madam. There was a video actually. Video has to be played. Go back,
Where?
madam. There'll be a play button in the down, madam.
Where? I
There
think we
will be
have
play
2
button.
videos.
3 videos, madam.
3 videos. So
there will be a play button in the down, madam.
Sorry. Okay. So there is one video.
Madam, we can't hear the audio, madam. We can only see the video. We just stop share first. Madam, stop sharing the video, madam.
Okay.
Go back
Video
and
all the
start.
slide.
Entire thing, madam. You just stop sharing.
Okay.
Then go back.
Again, I have to share.
Madam, just a minute. In the share thing, in the below left, you'll have a two check boxes, madam. One is share sound, and other one is optimized for video clip. Have you checked it, madam?
Three dots.
We can see only the video, madam, no audio. That's what I'm telling you. You have to check in the two check boxes. Stop share the screen, ma'am. Go back and stop share the screen. Or else I'll share the screen, ma'am.
The audio is not there. You're not able to hear.
No, ma'am. Before you share the screen, you will have two options in the bottom left in the share screen. Optimize with video clip and share sound. You have to click on both the check-ins. Then you have to share the PPT, madam, the video. Then only the video will play and we can hear the audio also. Or else if you ask me to do, I'll do that.
Optimize for video clip and share sound.
Share sound,
Okay.
yes, ma'am.
Okay.
Sorry, ma'am, we can't hear still now.
Second, let me do it. I think now you will be able.
Click on the play button, madam.
Social norms are the unwritten rules of
Now you're able
behavior
to hear?
that are considered acceptable in a
ma'am.
group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So these were the norms and stigma. Now the stigma and norms perpetuate disrespect and abuse. The category of disrespect and abuse can be physical abuse, verbal abuse, or sexual abuse. Then there is stigma and discrimination is also there. There will be a failure to meet professional standards of care, poor rapport between women and providers, and health system condition and constraints. So every woman who is seeking a abortion care, she has a right of freedom from harm and ill treatment. She had a right to information protection under laws like MTP and POSCO, informed consent and refusal, respect for choices and preferences, dignity and quality of care. And she has a right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. So the domains of respectful abortion care there are 12 domains of respectful abortion care. Being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, and continuity of care and counseling. So the time has come. We have laws, we have rules. Now it is time has come to strengthen the implementation. Since we know that now it is the responsibility of one registered medical practitioner up to 20 weeks for abortion. So the one provider has more responsibility. She has to counsel, give the and we have to they have to educate the people, and they have also to take care that we have to reduce the sex selective abortion. And then when we are dealing with the 20 to 24 weeks of cases, then the special cases which are coming for abortion, then we have to be judgmental free, we have to give timely services, and we have to be sensitive. And the respectful abortion care is basically we have to respect, we have to qualify and dignity at all types of abortion. We have to maintain a confidentiality, and we have to respect the biggest respect. As a provider, we need to be mindful of social cultural aspects. We have to If she's coming, if she's unmarried, then we have to be, we have to, we don't have to go for a bias, and we have to just provide the services to her. So this is a guide to avoiding stigmatizing languages while providing the abortion services.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use the term early term. Early term Use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high-quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
This is about the Saver Toolkit by WHO.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So we have come a long way from 1970. We were talking about the unsafe abortion. In 2000, we were talking about the safe abortion. And now in 2020, we are talking about the respectful abortion. So some recap questions for you. According to WHO, restricting access reduces the number of unsafe abortion. It is true or false? You can write your answers in the chat box.
Sally, little bit faster, time is running fast.
Okay. So it is false, and as already been told that when is abortion considered safe? When both the criteria are met, that is by appropriate methods and by trained persons. The MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. It's true or false? It's false. We can't deny the termination of pregnancy, but so reporting is still needed, but abortion services should not be denied, and we need to provide bias-free services without judgment. 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? The answer is no. She's in a special group, and with the permission of 2 RMPs, she can undergo abortion. So thank you so much. Let us make it safe and respectful for the woman, as abortion is legal in India. I would request Dr. Rekha to continue with the last module. Dr. Rekha, you have to unmute yourself. Unmute yourself.
unmute me?
Yeah.
Vaishali,
Now we can hear you. Yeah.
Yeah. Okay. Thank you so much, Vaishali. And now I'm going through the time is running short, so I can go fast. In pre and post abortion family planning services, counseling, and technology for referral in online counseling. So we go for with this topic. And what is counseling? As we all know, counseling is a two-way communication, not single we tell and patient or client listen. It is a two-way communication, and it always conversation between client and doctor or client and provider. So counseling is a structured interactions in which a person voluntarily receives emotional support and guidance from the trained person in an environment that is conducive to open sharing of thoughts, feeling, and perception. That means place should be conducive and we should be supportive in even in emotional as well as in guidance. So it includes counseling includes, this is integral part of comprehensive abortion services. This is an important as procedure. We always say procedure is more important. No, counseling is more important. If lady is counseled well, then she should opt, she might be opt the family planning methods in better way. And women may need help in decision making. Wherever needed, the spouse should be counseled. Most of the time we counsel only the female client, but we should counsel the spouse also. So adoption of the family planning method is much more better. So what we can do, we should help. In what way? We should help women decide about termination of a pregnancy, and we help the woman to choose the method of termination. And then we should ensure delivery of complete information. This is very, very important. We always in hurry. So we should ensure delivery of complete information about the procedure and help the woman to adopt a contraceptive method. Whatever she has chosen, we should explain and we should help the woman to choose the method, and then we should explain the method. This is just like a cafeteria approach. Previously we say this is a cafeteria approach. We always help the woman. So what includes the pre-procedure counseling? Ensure privacy and confidentiality. This is very, very important. Privacy and confidentiality. Otherwise, client will not be able to tell the problems. Be non-judgmental and be sensitive. Don't make any comment which are judgmental. And establish rapport. Rapport is very, very important. If there is good rapport, then everything is possible. And use simple language and allow the woman to clarify her doubts. If she has made her mind for termination of her pregnancy, then you should assess. Don't discourage. You should assess her for the procedure. And you should assess, you should help about the and counsel about the family planning services. Why we offer this family planning counseling in these services? Because quick return of fertility, even within 10 days, and at least 6-month gap is required before the next pregnancy. So we should counsel about the family planning method. Optimum, this is opportunate time, means woman is in contact with the doctors and providers. So you should counsel repeatedly, pre-procedure, during procedure, post-procedure, and even in follow-up. So you should counsel for that, then this increases the contraceptive acceptance. And along with that contraceptive acceptance, we should always tell about the health benefit and better future pregnancy outcome with the contraception, because 90% of abortion-related maternal mortality can be prevented by ensuring contraception. So it is very important to ensure this. What include pre-abortion counseling? When we start first visit, when women visit for the suggestion, and during consultation. Exception is only if there is any grief management or any delay because of some problem in the family of this woman. And what to counsel? Importance of return to fertility. Always tell this return within 10 days or to 4 weeks. Then second trimester. Help with choices. This is very important. Women should select and you should help in the choices. In method specific counseling, when she select, then you should go for the method specific counseling. And you always consider the high risk behavior. Suppose if woman is having high risk behavior, along with that she opted the IUCD, then you always tell about the condoms also to avoid the transmission of STDs. If the woman is not willing for any contraceptive method, do not refuse MTP. You should always do the MTP and counsel, post-abortion counseling, follow-up counseling. As such, we are not calling for the follow-up. But if she is not accepting contraception, then we can call on the day 7. Try and counsel her after the procedure. If she is still not willing, call her for the follow-up in a week time in counsel again. Assessing suitability, what abortion process is complete. Before the giving family planning methods, you always assess for the abortion process is complete or not. Is there any infection or not? And is there any injury to genital organ? And if chances of fresh pregnancy should be ruled out if after the 10 days or 14 days she return back for the contraception. Then post-procedure, what we should ensure woman has understood precaution and care needed during post-abortion period. Most of the time during pain, woman is not understanding anything. So you should ensure she understand the precautions and opportunity to counsel for contraception in case not previously accepted. Reinforce the need for continuing the use of contraceptive method, whatever she has chosen. We don't refuse. Continue. What is the post-procedure counseling include? Continue, reassure, repeat. Continue to ensure privacy and confidentiality, and we should reassure her in case of any problem, and repeat the information about post-procedure care in danger sign. Then, what in post-abortion family counseling? What is already opted? If she opted our family planning method in contraception method, then we should appreciate her and give immediate care, whatever she opted, either IUCD or methoxyprogesterone acetate. Or if she is taking oral pills, then if she is happy with the oral pills, we should continue these pills and follow-up protocols should be ensured. In continuity is very, very important. And we give the card after the giving the contraceptive method, then we should always give the card and we should write the date and timing of the any method, whatever we have given to that woman. And if she is in doubt and she has not decided, then we should allay the anxiety of the woman and importance of the immediate use of the contraception in whatever the method she choose. In extended period of adoption of the family planning, we should tell about the long-term use of this. In couple counseling is very, very important. And if she is still not ready, then we can give the EC pill at least. But EC pill not a contraception. It is a just used in the emergency situation. What are the methods used in different trimester? We should give the family planning methods or contraception in first trimester abortion and second trimester abortion. In most of the method, they are almost same, but in few cases, it is different. If the various type of contraceptive available, that is various method, IUCDs, and hormone, injectable hormones method, and permanent method. Before that, COC is also very good. So we go one by one. In barrier method, if we are giving condom in first trimester abortion or second trimester abortion, no problem. But this can be used immediately after the completion of abortion, as soon as she begins their sexual activity. And no hormonal side effect with the contraception condom, and can be used without consulting healthcare provider. Easily available, and they prevent against STI and HIV, especially useful, very useful in high risk behavior women or men, and enables men to take responsibility of contraception. Another method is IUCDs. IUCDs in first trimester and second trimester can be inserted immediately after the abortion and with up to 12 days after the abortion procedure. But it is very important to ensure the completeness of the abortion and to rule out contraindication before the insertion of IUCDs. But if lady is using if abortion by the medical method of abortion, then it should be used up to on the day 15th day of the abortion, day 15 of the abortion or day 15 of the medical drugs has been given. So, but it is very important to ensure the complete expulsion of the product of conception and to rule out infection beforehand. These are highly effective in provided long-term contraceptive, long-term reversible contraceptive method up to 5 years with IUCD 375 and up to 10 years with the IUCD 388. Can be provided, this is very important, can be provided by trained doctor, MBBS and above A&M nurses for the first trimester abortion. But after the surgical abortion, only by the trained doctor. After the MMA, only by the trained doctor, because confirmation of completion is very important with this type, this abortion. And PPIUCD trained doctor should insert in the second trimester abortion. No interference with the sex, and immediate return of fertility after the removal, and no any hormonal side effect with the IUCDs. Now we come to the post-abortion method, that is OCPs, COCs, combined oral contraceptive pills. In first trimester and second trimester, in both, this can be given immediately after the completion of abortion or up to the 7 days after the abortion, after surgical method. But with the medical method of abortion, this can be started on the day 3 when you give the misoprostol or within the day 15 of the process after the confirmation of completion. So with the medical abortion, completion is very important. In confirmation of completion is very important. In additional benefits with the hormonal contraception are they regulate the menstrual cycle. They can provide by all health workers after the first screening by the doctor. This is very important part. This can be provided by the ANM, ASA after the first screening by the trained provider. No interference with the sex, offer protection against the ectopic pregnancy, endometrial and ovarian cancers, and benign breast diseases like fibrocystic disease or fibroadenomatosis. And these are not suitable for the women who are breastfeeding till the 6 month of 6 months after delivery. Another method available, this is hormonal contraception. In first trimester and second trimester, in both situations, this can be used immediately after the abortion, completion of abortion in the surgical method, or up to 7 days after the abortion, completion of abortion. With the medical method of abortion, it can be started on the day 3 with the dose of misoprostol. In these long-term methoxyprostol acetate is highly effective. Confidentiality and privacy maintained, can be provided by doctor in the first time, another in the rest time can be provided by IUs, ANM, and health workers. And no interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effect with the hormone, injectable hormones, and offer protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and fibroids. Another method is permanent method. Permanent method includes female sterilization, that is tubectomy, or male sterilization, that is vasectomy. With the female sterilization, vasectomy can be performed at any time, not a time dependent. At any duration of after the abortion or before the abortion, at the time of abortion, male can undergo vasectomy. Very effective permanent method of contraception, no interference with sex, no long-term health risk. A couple must use another method for the few days till the sperm available. But in the female sterilization, this tubectomy can be performed after an abortion in the absence of any infection or severe blood loss. Concurrently with the abortion, just concurrently with the abortion or up to 7 days. In the first trimester abortion, surgical abortion, mini lap and laparoscopic ligation possible. But with the second trimester abortion, only mini lap ligation is possible because of large size of the uterus. And with the medical method of abortion, this should be done only after the first menstrual cycle. This is very important. In medical method of abortion, this can be done only after the first menstrual cycle. What are the advantages with that? This is permanent method of contraception, highly effective and effective immediately after the ligation, and no interference with sex, no effect on the breastfeeding, no long-term side effects, and offer protection against ovarian malignancy. So these all are the contraceptive methods we can use, and we can counsel about them, and we can suggest along with the abortion or up to the 7 days. With the this is contraceptive methods with the MMA, medical method of abortion. COCs, the combined oral contraceptive pills, can be given on day 3 with the dose of misoprostol Injectable contraceptive can be given on the day 3 with the misoprostol tablet. Centromen also with the misoprostol tablet. And IUCD inserted with the MMA on the day 15th day of abortion. And ligation with the medical method of abortion after the first menstrual cycle. With the vacuum aspiration or surgical abortion, COC can be given on the day 1 immediately after the abortion till the 7th day of the abortion. Injectable should be given on the day of abortion, just after completion up to the 7th day of abortion. Centromen also can be given on the day of abortion up to the 7th day of abortion. IUCD can be given with the up to 12th day of abortion after ruling out the infection, immediately up to 12 days. Ligation can be done with the concurrently or within 7 days after the completion of abortion. Various types of services available: sexual and reproductive health services, and importance of with these services, importance and use of teleconsultation in other technology are available. And so we can use this technology for the consultation and for the counseling purpose. So various technology available. These technology are teleconsultation, telecounseling, very much used in the COVID era. So teleguidance and telereference and telelinkage. These all technology available, and we can use all these technology for the counseling of patient, in consult, for the consultation, for the follow-up, in for the referring in various ICF material available. That is website like Hamdo. In social media site are Ask Tanu or YouTube media. You can use these medias for the counseling of the patient. In infographics available, helplines number are available in the online. In patient education platform also available in the WHO provided by WHO, Ministry of Health and Family Welfare, and as well as RCOC's material. And what is the sort of teleconsultation? That is strength, weakness, opportunity, and threat. What are the strength of teleconsultation? That are in COVID era very good, used in COVID era, and approachable throughout the process in with the confidence. Awareness spread out, question answer can be done with the teleconsultation. But what are the weakness? No face-to-face interactions, only audio-visual, but no direct face-to-face interactions, and demonstration also not very good with the teleconsultation. And opportunities are privacy and comfort. Patient can take the consultation at home, from home. So she will be very happy. So privacy and comfort is very good with the teleconsultation. Cost saving also, no visit, in number of visit can be cut down with the teleconsultation. Third is, she missed opportunities, and we also missed the opportunity to counsel her in misdiagnosis sometimes, because examination is very important for the confirmation of the diagnosis. So applicability of these comprehensive abortion services are assessment. Why we do the assessment? To confirm the diagnosis, and we confirm the need of contraception. In counseling, you can do the video conferencing, no need to come for the counseling or Zoom counseling. In follow-up can be done by the hybrid service, few follow by the attending to the hospital, and few on the tele method. In one visit with the rest all method, but with the MMA 3 visit required. First to take mifepristone, another to take misoprostol in day 15 to confirm, and to give the family planning method. So key messages are: realize the need of post-abortion family planning method. This family planning method in family planning counseling, and this is very important to reduce the maternal mortality and morbidity, and bring the couple on board and strive for 100% coverage. This is very important to give 100% coverage. Capitalize on the basket. We have the full of basket of the contraception in applicability in post-abortion period. Technology so much technology available in the scope for entry in comprehensive abortion care services. Concern about this is only policy in malpractices. Sometimes there is malpractices in service cost, in accessibility to the client. Adolescent reproductive health needs can be dealt with the online and offline both. And this is very important in present time. And so this is very important message. Every trainer has told this certificate will be awarded to participant on the attending the training in submission of registration, pre-test, post-test. This is very important. Pre-test, post-test, and feedback. All three should be completed. Before then you only get the certificate. So let's make it safe and respectful abortion. Thank you.
Thank you, Dr. Rekha, for such an elaborate talk. So with this, we come to an end of this session. And I hope you all have gained from this webinar. And I would request...
Question answer.
Yeah, there is no questions I've posted. Yeah, ma'am.
Can I just, Rekha, please stop sharing. Okay. We will need to have one picture with all the candidates, and also I will request the backend team, Dhira, so that if you have the link, we can post it in the chat box. May I ask Mr. Bashir, do you have the link to put it
Not
in?
Bashir, this is Sriman, madam. I'm doing that, ma'am.
Okay, all right. So till then, I will request all the members who have attended the training to put on their videos. Yeah. Very good. Because there are even members who did it last time but did not receive the certificate. Any questions in the chat box?
No, ma'am.
Yeah, there is one question that has come now. Do we need any separate registration of our center to conduct tubal ligation? Shelly has asked that. I think for the MTP services, this registration is required, but for the family planning,
tubal ligation, yeah, there is no certificate permission is required, but you need to fill a form.
All the documentation has to be complete. There are forms for the consent and everything that you must be having. But the center registration, it's like any gynae center where you're doing the other things, you can do the ligation also as a surgical.
And moreover, you need to send a compiled report, all the MTP procedures and the tubal ligation, whatever you are performing, you have to send that information to the CMO office also. And all the family planning services, whatever you are giving in your center.
So we can have, I think there are 3 pages. So all videos on, please. I'll take. And smiles. The second page, we don't have many. With the videos on, please. Videos on, please. Okay. Yeah, so, and I think the backend team has put the link for the post test and the feedback. When you do that, then only you will get the certificate. Can everybody see that? Yeah. In the chat box? Yes. So Dhira Vaugh has posted that link. So you take that link, click that link, do the post test, fill the feedback form. And once you have done that, then you will get the certificate. All right. Any queries on that?
Yes.
Okay. Now, Vaishali and Rekha, anything you want to say, please say.
Yeah, there is one question, like if adolescent and age less than 18 years, whose consent to be taken? Actually, as per the new law, you can't deny the termination of pregnancy. So it's not mandatory if the girl is coming, even if she is minor, you can provide her the medical abortion or the termination of pregnancy, but as per the POXCO law, you have to inform the appropriate authorities. So initially, permission of a parent or a guardian was must, but this
This word has been removed now. So
Yeah.
it's not mandatory to have the parents' consent in that case. So, but somebody has to take the responsibility.
Yeah,
Because,
but
that is right. Okay. Any other questions?
you can unmute yourself and you can ask question if you are you have some queries.
I think for the Lucknow Society, we have covered quite a good number now. Hopefully, we will not need any more programs. Only if there will be demand, we will do that.
Is another MTP license. See, actually, you have to register, not you are allowed to provide the MTP, but your place has to be registered. Whatever place you are practicing, whether if you are giving you are doing MTP, then your place has to be registered. The law is same as in 1971, the person, the place. So the place has to be registered in which you are providing the MTP services. You are a medical practitioner, but if you are providing, if you are a medical, your place is not registered, then you should do an MTP in a place which is registered.
So what she is asking, that she already has MSMD degree, does she need a license separately? She doesn't need it, is an implied one, no? Does she need for herself? Somebody who has a degree.
Yeah.
Registration is important. Just
your place need to be registered. You need not to. Yeah, you can provide the service.
Okay, then I think if there are no more questions, we can close, and I'm sure all of them are clicking on that link, and right.
Thank you, everyone, and thank you.
Thank you, Vaishali and Rekha, for completing the training sessions. Dr. Yashodhara just left. So on behalf of all the logs office bearers, I thank all the members of Jaunpur and Lucknow OBG Society who have joined today and made this training successful. Thank you, Amber.
Thank you, ma'am.
All right. So we leave it now.
Yeah.